Child from the Tavistock Institute of Human Relations. We're just going to quickly whiz Simon there, can introduce himself.
Hi, I'm Simon from Involve.
Anthony is behind me.
I'm Anthony from the Democratic Society.
Morning.
Hiya.
And over there is...
I'm Catherine from Public Eye.
And she's hiding behind a pillar, but she won't be for long. The four of us are the leads from our different organisations. Olivia Butterworth from NHS England will introduce her in a bit later on. You'll hear more from her. Her team sponsor this work. It's very nice. Actually, I recognise a few old faces from the different events, indeed. From NHS Expo, I didn't come to the earlier design days, but from an earlier July event, from various different things that we've been doing around the country. And we thank you very much for coming, and we welcome anyone who hasn't worked with us before. The point of these 2 days is around working. What we don't do, it's our ethos is to work in public, so you'll know that there are cameras. It's doing. Oh, thank you very much. The way that we work, the way that we think about how we go about our work. One of our things is going to be about jargon busting, and I think we're going to get some good interventions from over there.
I'm a jargon buster.
Yeah.
So are we.
So, it's about working together. That's what we're doing. It's not about us taking control or NHS England taking control of NHS Citizen. It's about co-creation. That means working together. Co-working, thank you. I'm going to hand over to Simon, who's going to talk about some of the sort of practical issues over the 2 days.
Camilla gets to do all the exciting stuff, and I get to talk to you about toilets. The toilets are just there. So as many of you know this building already. There is no designated fire practice, so if the fire alarm goes off, it is a real thing. Go out of that door there, and I've been told to press the green button to get out, but I suspect you can. It's easy to get out. And we meet in the church car park. If you do smoke, don't tell anybody else here, and you would go outside the main building and turn left. If you've parked, you need to get a permit, so you might want to head out now and go to the front desk and get a permit, otherwise you will get clamped, I think. If you can place all your cups on the trolleys, then we can kind of keep them circulating and have new cups. Many of you are really busy, and we know that we're going to have tweeting and other forms of engagement with people outside the room, but if you could put your phones onto silent, that would be really helpful. Thank you. We are going to be webcasting, so we've got, as Camilla said, there are cameras around the room, and what that means is that people who aren't here can contribute. The way we're trying to do this is to take this not just to physical events, but to bring people who are outside the room into the room, and we have somebody who's going to be doing that for us, who we'll introduce in a minute. But what that means is, if you're speaking, can you wait until you get a microphone? Because otherwise, although the people in the room can hear you, the people in the world can't hear you. Sean.
I need to ask you a question.
A good point about the microphone. I'd already forgotten my own instructions.
To ask you a question.
Yeah.
I want to promote our event at Chains on the June the 26th. It's about this event is about shutting down institution. It's for people with learning disabilities to have a voice. It's just for people with learning disability. Professors can come, but they've got to opt out. And people with learning disabilities can opt out too.
Well, what we might do is give you a proper slot where we can make sure that people are focusing on that, and we'll try and come back to that. So if you are a tweeter, then can you tweet out under the hashtag NHS Citizen? And if that doesn't mean anything to you, don't worry, but we will be bringing in the people who are using Twitter into the room. We have 4 rooms. We're going to be using 4 rooms. There's this room, there's the boardroom, there's a room that says Involve on it, and although I'm from Involve, that's very confusing. We're not using that room, that's room 1. So we're using the boardroom, room 2, and room 3. And so if you break out and you want a bit of space, then those are the rooms you might want to go to. Room 3 is very good because it's got sofas and leather armchairs, so you can relax. We've got a sticky wall here for capturing people's thoughts. We're going to be capturing questions, comments, and everything else. It's not just for us to capture. If there's something you want to write down because we've missed it, or because you think that Huda or Leslie have expressed it wrongly, then you've got card on your table. Can you make sure you only put one idea per card? I'm going to hand over to Olivia, who's going to stick it on the sticky wall. Yeah, 3 to 7 words per for each idea. If it's less than that, it means you haven't really thought about it enough. And if it's more than that, then it begins to be an essay. So the shorter the better, but not too short. Write nice and big like this so everybody can see what you've written. Don't write like this because people can't see what you've written. And now that, because the jargon's been brought up, what we do, one of the things that can be very disempowering, can really remove people from conversations, is when we start using jargon. So if somebody uses a word, if they're in full flow and you don't want to stop them, don't feel you should. But if you want them to define the word, stop them and ask them to define the word. And then either Huda or somebody else will go and write it up on the jargon walls. There are a number of them around the room. And you should feel free to write up words that you don't understand on there. And then you've got sticky dots on your table. If a word is a particular problem for you and you really think that we need to be defining it as part of what we're doing for NHS Citizen, if you can put your vote on it, then we will know that that word needs particular attention. So those are the practical instructions. Has anybody got any questions about the practicalities before we actually get into the day and do the real stuff that we're here for? Huda. Oh, wait for a microphone.
If people want to add their Twitter handles, there's also a sheet at the back. It helps so we know who you are.
Thank you, Huda. Thank you. OK, so I'm now going to hand over to Olivia, who's going to just very briefly tell us why we're here.
Hello. Thank you very, very, very much for giving us your time and coming today. It's greatly appreciated. Good morning, Change people. Going back to March was a real point in time for us in developing this work. So my team's role in NHS England is to amplify and to act as a conduit to ensure that the public's voice, citizens, patients, carers, self-advocates, people who use the NHS and social care have a voice in the way that NHS England does its business. And in March we did quite a scary but really exciting event called the NHS Expo in Manchester. So over 2 days, and we had a community space in the middle of it. We ended up having a fantastic conversation about accessible information, and it was quite a powerful amplification of why we're trying to do this and to do this differently. It was a really rubbish word, wasn't it? You're not being rude at all, Sean. So we made people's voices loud, and we gave people an opportunity to have a voice. Is that a better way of saying it? Thank you. So today, we're reviewing where we've been on this journey over the last year, since then, and since before then. So we started on this journey back when Tim Kelsey was appointed as National Director for Patients and Information, and his passion around making sure that people have a voice, that patients can hold NHS England to account. So that means actually have a voice and be heard and have their issues acted on. Sean, I'm going to stop you because you don't have a microphone. You can only speak if you've got a microphone. And I'm only going to give you a microphone when it's time for you to speak, because I'm a control freak. Okay? Cool. So, our objectives for the next 2 days, the things we want to do over the next 2 days, and where we get to at the end of tomorrow will be a test as to whether we've managed to do this, are up on the slide. I'm just going to read them through because this is what we're here to do, and I want everybody to sign up to this is what we're here to do, if that's okay. So we're here to share and discuss what we've learnt, and some of you have been on this journey with us, Kate, since October last year. We want to spend some detailed time, some really intense time, working on what NHS Citizen looks and feels like to you in your many different roles that you play. And we want to agree the important questions that we need to continue to think about and start to think about answers to, that we have to have answered by September 2014, so by September this year. And September this year will be NHS England's second annual general meeting, where we will model what this might look like as a full assembly meeting. So we've got quite a lot of work to do between now and then, and so today's 2 days, and your input into this, and everybody out there who's watching on the webcast and who's going to join us on the Twitter conversations is a part of creating that. I'm not going to say any more than that. I'm going to sit quietly in the corner.
She's not, actually. We're going to call her back in just a minute. So we're now going to, because the next slide is going to come up seamlessly, just tell you a little bit about what NHS Citizen is. But just before I do that, let me just briefly tell you what the shape of today is going to be. So the morning is largely going to be giving you a chance to engage with us, to talk to us, and to think about the system and how we're working and ask questions so that you understand where we think we've got to, ready for in the afternoon for you to start saying, what does this mean? How would this work? That's rubbish. That's great. So we can then begin to tear apart the work we've done and actually improve what we've done and make NHS Citizen better than where it is. So this morning is a bit of a kind of to and fro, helping you to understand what we think we've done. And the afternoon is over to you. We have some questions we want to ask of you as well, but it's over to you to say, well, this is how you could improve it. This is what needs to happen to make it better. So that's the shape of today. And then tomorrow, we're actually going to be testing it. So over the evening, we'll rewrite the document. And then tomorrow, we'll actually be testing 2 of the bits of NHS Citizen and seeing, is it now working as we would like it to work, or do we need to change it again? So that's what we're intending to do. And you all have received a copy of the full vision document, this horrendous 40-page document. And then there is also, as Craig is holding up, the easy read document as well. And there is a simple summary too. We know it needs to be simple, but actually getting there, you need to go through the complicated stuff to get to the simple thing. If I try and give that to my mother, she'll glaze over. We need to have something that my mother can understand, and I hope she's not watching the live cast. But to get there, to make it work, we need to understand properly and in detail how it's working. So, Olivia, the question I want you to answer is, what problem is NHS Citizen trying to solve? Why has the board wanted to set up NHS Citizen?
So I might describe this quite badly. I love this. You're just going to barrack me now for 2 days, aren't you? Thanks. So I think the problem that we're trying to solve is that we have an NHS and we are changing as a society. NHS England has a particular set of jobs to do. And part of those jobs is about the future of the NHS and the healthcare that we want to be able to access. It can't do that on its own. It has to do that in partnership and with the people who use and work in the NHS. So it ceases to be a them and an us, and we create an environment where we bring people together to think about how we work together and how we look after our own health better together and how we influence the services that are provided for us and that those services actually meet our needs. To do that, it needs to be able to have a very loud voice that's evidence-based, that's sharing the practice around the country into it. And how do we do that when there are multiple different voices out there? And actually, it becomes a competition. There are many different voices out there. You put your hand up every time I make a really rubbish word come out my mouth, and I'll try and keep looking at you, Sean. So many, many different voices. We've got Health Watch, we've got citizens advice bureaus, we've got self-advocacy groups like Change and Changing Our Lives in Birmingham. We've got local government, we've got elected members, we've got all these different voices who often compete with one another to be heard. And actually, how does NHS England and the board of NHS England genuinely listen and hear and respond to all of those voices in a way that it isn't a competition, but it's a way of working together so that we make those voices louder, we bring them together, and we have greater impact. So The problem this is trying to solve is, how do we do that? How do we really make sure there is a direct route for people to have a voice, be heard and responded to by the boards of NHS England on the issues that it can take action on?
Olivia, thank you. Thank you very much. So what I'm going to do now is I'm going to hand over to Anthony, who's very quickly going to tell you about the NHS Citizen system and how we're working. And I'll do the slides so you can go to the front.
So, as Olivia... Good morning. So, as Olivia has said, NHS Citizen is trying to do one very hard thing, which is to find the way of getting 50 million potential people in the NHS, or potential users of the NHS, to have a way of getting their voice to a board that's made up of 12 people, 15 people? How many people on the board?
Just short of 20.
So 20 people. So 50... Can you move away from the speaker? You want me to move away from the speaker? Okay. So, here all right?
Yeah, that's fine.
So, it's trying to do a hard thing to get 50 million people to have a voice to 20 people, without those 20 people being absolutely overwhelmed by the different voices and opinions and things that they're hearing. So what we've done since October, through 6 versions of this document, and we'll produce a 7th this evening, is to come up with a way of making those voices connected to each other and giving them a way to run through their ideas and have conversations about their ideas before they get to the board. So we start at the thing that works most closely with the board, which is the assembly meeting. And in our vision of NHS Citizen, as it stands today, though it will change, we are saying that it will be held twice a year, and it will involve the board, but also the people who have been active in NHS Citizen having conversations during the preceding 6 months. So that's where we start. That's the place where the board meets the NHS Citizen system. However, we have to get ideas and issues and problems into the board, and we have to make sure that they are not just someone's thought that they came up with that morning, but something that has been properly worked through. So this is what Discovery is meant to do. Discovery is meant to go right out into the entirety of the NHS system and find all of the places that people are talking about the NHS, whether they're doing it on a computer, whether they're doing it in a meeting hall, whether they're doing it through a patients group, or whether they're doing it through an organisation like Diabetes UK. Discovery is meant to find all of those conversations that people want to be brought into NHS Citizen and connect them up and make them stronger by being connected and provide evidence for them as well. So you can see around the ring the sorts of things that you could get into Discovery. So Discovery is meant to give an overview, a sort of view from the top of the public conversation about the National Health Service in England. The bit that links those two is Gather. And Gather is a place where, out of that big public conversation about the NHS in England, people can say, I think the most important thing that we should be talking about is this. And by saying that, they're not only saying, I think this is really important, because there's all sorts of things that are really important. They're saying, I think this is really important, and I'm going to take responsibility for leading a conversation about it. And so Gather is the place where the big fuzzy public conversation about the NHS moves into a conversation that is based on evidence and where people are able to sort out the ideas, not just to go to the assembly meeting, not just to go to the board, because sometimes people will put in ideas that are about local services, sometimes they'll put in ideas that are, not really of national scope or significance, and those ideas can go to the right place. So what comes out of the Gather space won't always go to the assembly. In fact, it probably won't usually go to the assembly. It'll usually go to the right part of the NHS to answer the question. And so that's how we imagine these 3 spaces working together. Next slide. The biggest part around that is the broader human relations world. Now, human relations means just what it says. It means the relationships between the people that make up these conversations, but also the people in the health service who are responding to them. Because we could have in this room or on NHS Citizen the best conversation in the world about the NHS. But then if we took it to the NHS body that is responsible and they didn't want to listen, then we might as well not have bothered. So for us, human relations is the essential part, the most important part, underpinning all of the structures around conversation. Because if we aren't prepared to talk to each other in the right way, and if the NHS isn't prepared to listen and talk back in the right way, then we can all go home. So I think that those are the 4 circles of NHS Citizen. And I don't want you to think that the Assembly is the most important, it's the World Cup finals, and human relations is the conference. It's the bit where everything starts. It's not like that. They're all meant to be connected, they're all meant to work together, but actually it's all about creating a better public conversation about the health service.
We all agree with that.
So this is a very quick description of how we've got there. We started in February 2013, so over a year ago, where the NHS England board said they wanted to think about what this thing might look like. Then in July, there was a stakeholder workshop which said, actually, no, this is a good thing to think about. This is the right thing we ought to be doing. So, can you work it up further? What should it look like? And so in October 2013, we met for another 2-day event like this, and we said, right, here's our first ideas about what it could look like. Here's the first thoughts. And we've been working on regional events around the country. We've done, I think, 4 or 5 now. We're going to be doing another 4 or 5 and more over the course of the rest of the year. And we are trying to, at each of these, go over the whole system, but also focus in on a little bit of it so that we can fix some of the things that we see that don't quite work. We can make sure that people are happy with it. And so from here, we are going to carry on with the regional events. After these 2 days, produce a new version of NHS Citizen. We're going to carry on with the regional events. We're going to spend the time between now and September in 2 kind of really busy periods, making sure that the thing actually exists and works, running up to the annual general meeting in September that Simon was talking about, and then we'll carry on developing it through until April, when hopefully it'll be ready to stand on its own 2 feet.
Anthony, thank you very much. So just any questions at kind of a high level of anything you don't understand at this stage? Because we're going to go into more detail, but questions about either how the model's working or how we're developing it, yes. And if you could say your names at the start so we all know who you are. And Sonia, if you can take a microphone.
Right, my name's Steve Sharples. One question which came out in my mind, you're going from base, which is the doctor's surgery or practice surgery, right to the top. How, at this stage of thought, how people like practice with no PPGs are going to take that on board and work upwards? One of the practices in my area will not have a PPG.
Right.
They refuse point blank to talk about it.
Can you tell me what a PPG is?
Yeah.
So patient participation group or patient reference group.
Okay.
And I think there's a conversation for us to pick up throughout the course of the rest of the day, definitely.
I think so. That is going to be captured on there, and that's an important question to answer or to think about. Stuart.
Try that one.
You must know me. Stuart Wallace. We talk about the citizen, and yet we all know there are those people out there that don't have any interest, mainly because they think they're excluded. And yet you talk about the voluntary sector, very valuable, but let's be honest, fairly small. When are we going to start talking to employers to bring those in? And when are those people who are experts in employer engagement going to get actively involved?
I think that's a really important question about what other conduits, what other channels, streams could we be using in order to do that. I have Dawn and then I have Sean. An unintentional rhyme there,
Hi, Dawn Pomfret from Transforum in Manchester. My major worry is if we're not careful, this could end up being hijacked as usual by the loudest voices, and the weakest ones will get trodden underneath. And my one major worry is that everyone needs something different, and when you get so many voices clamouring in the darkness, who the hell's going to pick it up? That's the worry I've got with NHS Citizen, that it could end up being swamped.
I think that's a really important question. In the document is a set of principles and behaviours as to how we hope we're going to work, and a kind of statement of how we want to work. And one of the questions I'm really hoping we can burrow into today and tomorrow is, as we design this thing, are we designing it in a way that will ensure and help us to stop that happening? Or are we actually getting it wrong, and what do we need to do differently? That, for me, is an absolutely critical question. Sean.
I'm Sean. I'm from Change. I'm a person with learning disability and a patient with learning disability too. I worked with a lot of people with learning disabilities around the country, around issues around accessibility. That they feel so frustrated when they go to doctors or the people at the desk, section. They feel that they look talked down to them, and the information they get is not accessible. And they told me they want everything to be accessible with verbal and written form. We want NHS to listen to us, because you want to improve your work. You've got to listen to us too, because we are your bosses.
And I think that comes back to Dawn's question, which is how do we make sure that the people who find it least easy to engage and are cut out by language and so on can. Jagdeep, yeah.
Thank you, Simon. Can everybody hear me? Yeah. I'm an optimist, and I'm
just
really
say who you are.
Jag Passan from Leeds Involving People. The questions I've got is, how does this work fit into NHS England's board priorities? Yep. Secondly, is the ambition that we're going to be looking at having a service user on the board that might be elected from the public? And then finally, there's tons of local models, as me and Simon spoke 3-4 years ago.
Is it that long?
Yeah, many years ago now. And it is right. How do you guys, with the big job you've got, ensure you tap in to all the voluntary sector and all the pieces of work that are happening locally without going to the usual suspects? And I think that's an issue I haven't got the answer for.
So I've got loads of hands.
Can I just mention the one thing I should have mentioned? In that Simon Stevens spoke, and there's an NHS Health Service Journal article.
Just tell everybody who Simon Stevens is.
Simon Stevens is the new Chief Exec of NHS England. So he's a terribly important person. So he described the NHS Commissioning Assembly, which is the gathering of all NHS clinical commissioners together, and NHS Citizen as being two of the transformative routes through which we need to improve the way we work together and do our business. And he said that in his first month in post. That makes me terribly happy. So there is a very strong, very loud commitment from Tim Kelsey, from Lord Victor Adebowale and Kieran Devane, who are two of our non-executive directors. And as for that thing about whether we have a seat on the board, I don't know. You know, I think this is about how do we create spaces to have powerful conversations that are acted on. I'm less interested in whether there's a seat with somebody in it who's then not necessarily listened to.
So, thank you. I've got Sean. I'm going to say, can you hold your question? Because I've got 3 people who've put their hands up, haven't spoken yet. I'm going to come to you. Then I'm going to stop the questions, not because I want to stop the questions, but because I think the questions are getting into actually what we want to do this afternoon. So I'm going to take the 3 questions that people I've seen, and then we're going to go into the next session, and we will keep, the agenda is then basically going to be handed over to you. So this is not me saying stop asking questions. It's me trying to say let's get into the point where we can structure those questions and actually work on them together, if that's all right. So I'm just going to come kind of across the room geographically, as it were. Just remember to say who you are.
Jimmy Allen from Oldham. I'm a patient representative for PPG Health Watch on the Banana Acute. And my question is, are we going to involve the hospitals, trusts and that, and maybe there are patient forums, because that they have a voice and all besides.
I think, and so we're getting a number of questions about how we connect up existing places where citizens and patients and so on are having voices. Yes.
Thank you. Thanks. I'm Max from Bradford.
Hi, Max.
And I was just keen to know, I think this is a great idea, great process. I like Olivia's point about a loud voice coming to the board of NHS England. I suppose where I see a gap at the moment is what will happen when that loud voice gets to the board. Because obviously if the board have the opportunity to simply reject everything they hear, then nothing else happens. So I'm keen to know what the process is to ensure that the board are held to account in some way by that loud voice.
So we will. We're going to have a session all together for an hour, and then we're going to go into a bit more detail about each space. And then you can say, that ain't going to work, let's change that, or that will work. Great, job done. Yes, and then...
Good morning, my name is Paul Adley, working for Change. Make sure, because I've got autistic spectrum, because our behaviours can be different, so be understanding, patient and tolerant, because our behaviours can be different or not acceptable sometimes because of where we are. So be understanding, patient and tolerant to all patients, to be listened and respected. Thank you very much.
That's a very great lead in. I'm not going to quite lead into the session that Camilla's going to go, because I do want you to know who else from the team is here, so you know who else you can go and speak to before we then properly get into the meat of it all. So, can you stand up, and if you're obscured by a pillar, can you unobscure yourself? Can you stop hiding yourselves? So we have Clive Mitchell here from Evolve, who is our troubleshooter. If it's too hot, too cold, the lunch is rubbish, go and talk to Clive. We've got Mel Stevens here, who's going to be blogging. She's going to be writing and posting up on the NHS Citizen site, and she's going to come and ask a few of you over lunch whether you think you now understand what NHS Citizen is after our introduction, and if you don't, what we'd have to do differently to make sure you do understand it. And then we've got Tilly right in the back. Come and show everybody who you are, Tilly. Come to the front. Tilly is our social reporter. She's on Twitter trying to bring in people from all around the country. You can't quite be seen because of that pillar there. Now Sonia, where's Sonia? Sonia here is from Involve, and she's a researcher at Involve, and she's working with Mel on the blogging to tell the story of what's happened today. Leslie here is from the Tavistock Institute for what? Human Relations. Sorry, we had a joke about their name this morning. And he's working with Huda Davis from Involve, and they're both capturing all of the questions, all of the points, so that we don't lose them, and we can take them into the work this afternoon, and everything gets picked up that you say. Now, I am pretty confident I can't see everybody. We have Nagina from NHS England and Rebecca from NHS England, who have basically driven the whole process and made this happen. And again, if you've got any practical questions. Now, I'm working by sight. Who have I forgotten? Done, Clive?
You have. Can I just add? Folks, can I just add to say that I'm also going to be sort of keeping an eye on the Twitter feed. So if people outside of this room are tweeting about the event, I'm going to try and bring their comments into the room. If I inadvertently, if you're in the room and you're tweeting and I just capture your comment, just put your arm up, just so it'd be nice to sort of recognise someone in the room who's tweeting as well. But to the folk outside this room, please do tweet and we'll try and get your comments into the room. Thank you.
I've just thrown water over myself, which is a very good moment to give over the mic. Camilla.
Okay. I'll come back down here. Quite a lot of the work that we do is about, in this room over the next 2 days, are going to be around sitting around tables talking to each other. So we thought we would have at least some part of the time when we do a little bit of moving around. Not all of it. Don't look too aghast. It's not going to be too horrid. I'm the lead person with Leslie over there, as we said, from the Tavistock Institute, thinking about this human relations aspect of the work. So we're really interested in those kinds of behaviours, the kinds of conversations, what has to change to make it so it's possible that people actually hear each other. The questions around the tolerance, actually what happens if you get to the board and nobody is listening, are really important for us to understand. And we're trying to work, we would like to work with you to really kind of pin down what some of the barriers are to effective communication, whether they're whatever they are. I'm not even going to kind of prompt you, so we're hoping it can come from you. So what we would like to do, because this is based around quite a lot of conversations, we've got a series of 4 different types of conversations that we want to have over the next hour. We would like to muddle you up into groups. Because I think you've probably sat with people you know a little bit. You do need to move into groups. I won't make you do that right now, but when we do, I suggest the groups on the table sizes are quite good. You 3 probably need to go and join others. If you just walk to another table and make sure you're muddled up. Okay, is that all right? So you're not with people you know particularly well. What we want to kind of have is a cross-section of different roles in the conversations. What we want to start with when you come to get together, and we've got this on some sheets, which I can't remember where they are. They're behind me, so we can...
I'll do that. You keep going.
If you can... Anyway, I will talk. We want to, first of all, sit on your table, but if you can find some little spaces to have a little conversation together. So in half your group, so you're not in too big a group, tell each other about something that you're really passionate about and speak from the space that you're really interested in. Preferably not to do with your working life, something different, something that belongs to you that you can share with someone else. And then we would like you to, keeping that passion, speak from, if you can, speak from your working role, your job role, or your role and your space as a citizen, to tell us what you think, tell each other what you really think about this NHS Citizen idea and how it can work and where it's coming from, what it speaks to you, speak to your enthusiasms or your difficulties. And that will be another few minutes. And we'll help you with the timing, don't worry. But then the bit where we want you to move, and we're going to demonstrate this because we thought this would probably be the easiest way. Yeah. What we want you to do is to kind of create a physical map, not really in terms of climbing on top of each other, but like moving around in a space to really understand what it is about the relationships to each other that work or don't work. And we thought that by doing it by moving, you'll actually see where you are in relationship to each other. And I think when we were practicing earlier on, where should we do it? Over there? Okay, you're going to watch us over here.
Are you all going to be able to see if we go over into that space? I wonder whether we shouldn't just... Let's just do it in the front. Yeah. A webcast
Oh, okay,
as well.
of course. Now we've got different roles for you, and they will be on your sheet. And over in that corner on that table over there, you'll see some sticky notes. So if you put them on yourselves, it would be really helpful. I know that the roles we've made up are not going to work absolutely, because we know it every time we do something like this. The voluntary sector and the advocacy roles are muddly. If you think you belong to both, put 2 stickers on. It's much easier than to decide. So we're playing different roles. I, for the purposes of this demonstration, am a citizen.
For the purposes of the demonstration, I'm a nurse.
I'm an activist, but I've got no microphone, which might be symbolic.
I'm a consultant.
He doesn't need a microphone.
I don't need a microphone.
That's for the webcast.
I do.
Yeah.
Oh, you're on there. I'm an activist.
I'm a consultant.
And I'm a commissioner.
Okay. Right.
Very interesting.
Would all the actual commissioners in the room like to put their hands up now?
Let's give them some love.
Right.
I'm scared.
Okay, so now we are going to have... I am going to think myself as a citizen into a problem that I want to solve for me, and they are going to be doing the same, okay, around my health problem. I have quite a close connection with this nurse here who I see, who I'm going to edge up to quite closely. And I really don't know that person over there who I would quite like to turn away from. And I'm kind of not sure about that person with the back standing, who I actually would really, quite like to go and see. And
I'm sorry. I feel very strongly that you need to come and talk to the commissioner.
But I have nothing to say to a commissioner.
But the commissioner, look, I've got a citizen for you.
Sorry,
I think you need to pay attention.
Well, who I want to
You
talk
need
to is the consultant.
As a consultant, I'm
Yeah,
much
but
more interested in talking to the commissioner.
I think I can speak to you on that.
Please.
I think I'd like to just talk to the consultants.
Yes, we can have a proper grown-up conversation without these nasty patients.
See, they don't understand, though, do they? They don't understand.
Okay, so if you can see, it's the kind of thing we want you to just have fun with, but really think from your roles in that situation. If you want to take on someone else's role, it'd be quite nice if there was a commissioner in your group. Do so, but work to begin with from your roles. And sort of move it around, and you can work it through and take just a few minutes on that. And then if you can think together how you might improve it, what would need to happen to make that system work better? Who needs to talk to who and how? And then if you can write down on maybe one of those, one sentence or something each, or as many as you want. We aren't going to have time to come back together. So what would be very helpful is if you could put it up roughly under the human relations thing, sometime during the coffee break.
I've just been asked a question by somebody, and I'm sure it would be the same for many of you, who, what happens if you have many roles? There'll be people who feel themselves as citizens, as inside the system, and so on. We haven't got a lot of time, and so if you can just pick one of the roles, but then as you go through it, you might want to think, well, what does that mean for my other roles? But I'm afraid you're going to have to make a choice right now, but we would be very interested in how you think about what that means for you in your other roles and what that means. But start off by picking one.
Okay, are you all right to move if you all stand up and move to another table? So you're a mixed up group. You can come back to your tables and your stuff later, so don't worry. Oh, one more thing now. We have got some other spaces because we know that for the moving around bit. The rooms, Simon, can you say the rooms again?
Yes. So the rooms, just so you're all very aware of the rooms, the boardroom is right at the back, and then you'll pass rooms 2 and 3 on the way, but Nagina will also show you where to go.
Lights, camera, action.
Hello again, folks. Well, hopefully you can see us moving a bit more humanly now. Apologies for the broadband woes and the stuttering we were performing earlier. At the moment, sorry, to introduce myself, I'm Clive from Involve. This is Catherine from Public Eye. Just to let you know, the room at the moment are doing some group work around how people relate to each other. So whilst that's going on, we thought we'd do a few talks to camera, a few short interviews, just so that you can pick up some of the thinking and learning that we're going through in preparing NHS Citizen. So I'm going to talk to Catherine about the work we're doing to try and make NHS Citizen more accessible and more inclusive. So Catherine, if you could just sort of outline how we're trying to do that.
This is kind of like an exam because we did the interview when the broadband was bad, so now I've got to try and remember to say the same thing. So, you know, obviously accessibility has always been on the list. You can't really be doing public participation and not be thinking about accessibility. But is at the Expo, a lot of people really wanted to have a conversation about accessibility with the Board of NHS England and really articulated it very well in terms of actually, you know, this is not something that is okay to do later. Actually, if we really want to build something which is genuinely public and open, then we need to design it in from the beginning. In the same way as, you know, there's a wheelchair user there who said, like, build the ramps in from the start rather than just sticking them in as an afterthought. And it was a really good metaphor. So what we're trying to do is we're trying to look at access and inclusion as being they're connected but slightly separate type of things, but we're trying to solve them in the same kind of way, which is if we genuinely create an open and accessible space, then actually everybody is better able to participate. And a good example of that would be for a lot of people, you know, sort of these kind of events can move very quickly. You can end up with some very confusing language, some very confusing kind of conversations going on. So we're trying to do two things. One is to have an active challenge around the language, so that we've got a jargon buster wall and that people are being very forthcoming about telling us when we're using jargon. But what we're also trying to do is to put in more reflective time into the physical event, so that actually that people who want to process things at different speeds, and actually, you know, we all of us go a bit too fast most of the time, is that actually if we design that in, does that become a benefit to all of the participants? So that's what we're trying to do now, and the session we're doing at the moment about talking about power and behaviour at the beginning of the event hopefully makes us more conscious of power and behaviour throughout the event. So that's just an example of some of the things we're trying in the physical events, and obviously we need to mirror that in the online spaces as well.
Great, thanks, Catherine. Could you say a little bit about, one of the sort of features of NHS Citizen is that there will be a big digital element to it, a big online element. Could you say something about sort of accessibility within the online world, but also how the offline world, people who don't use the internet or don't want to use the internet, how that will sort of work within NHS Citizen?
Okay, so I guess the first thing is to say that, you know, sort of, yeah, we're going to make the best possible use of new technologies because they're there and they should be used to create public good. We should be using them to help us make better decisions. But we need to do that in such a way that we don't make it an exclusive environment. And there's a couple of different things on that. I mean, one is around good design of your digital spaces so that actually they accommodate people with different needs around interfaces and things like that. There's another part here which is, you know, for instance, connecting to the work the Tinder Foundation are doing around digital inclusion, but being really aware that actually, for instance, it's and Ofcom have just published some data about this actually. It's not actually just older people who are not online. People have got a lot of stereotypes about who's online and who's not online. You know, actually, the over 65s are one of the fastest growing groups online. And so it's about being really aware of who's there and who's not. It's about designing the spaces to be as inclusive as possible so that actually different access needs are accommodated. But then it's also accepting that some people won't want to go online or really genuinely will not be able to, however much access we put in place. And what we're going to be doing there is we're going to be finding online-offline connectors. So people who are able to bridge the gap between the online and offline space. And in the same way as we're webcasting this physical event so that it's available digitally, get people to report on physical events and to speak for the people who can't come online. It's not going to be perfect, but we think it's going to be, you know, it's going to make a big difference in terms of how we manage to build up that big picture of what the whole conversation is. And that was really distracting because Simon just put up a sign saying we've got the plenary in 2 minutes' time. So I'm multitasking and telling you that as well. We're about to go back to plenary.
Okay, great. Okay, great. Well, thanks, Catherine, for that. And if we are 2 minutes to the plenary, then I won't carry on the conversation now, so that we can relax.
Do we not have 2 minutes of filler?
Well, I suppose actually, is there? I could grab Leslie to talk a little bit about human relations. Yeah. Okay. What?
Okay, I'm going to leave Clive here chatting to you by himself, and then
I'm going to go and
find Leslie.
Thanks, Catherine. Okay. Well, hopefully the broadband is working now, and you can see the event happening well, folks. We're just going to pull in one of my colleagues, Leslie Brissett from the Tavistock Institute, to talk about how important human relations is within any system that involves people, but how we're trying to make it a centrepiece of NHS Citizen. So bear with me, and we'll see if we can get Leslie to come and talk a bit about that. And here he comes now.
Greetings.
Hi, Leslie. Hi.
Are we on?
Yep, we are. Folks, this is Leslie Brissett from the Tavistock Institute. We're doing an exercise at the moment, Leslie, in the room about sort of relationships and how people relate to each other. This is very important for us in terms of NHS Citizens, so how people relate, power relationships, personal relationships, interactions. Could you say something about why it's important to NHS Citizen, why human relationships is a sort of a key feature, a key glue, a key foundation, if you like, for NHS Citizen? Why is it so important?
Okay, well, NHS England decided that they wanted to have a system that allowed them to be held to account by the public for what they were doing with public money. And the bedrock of that is the relationships between the people who work for NHS England, between the board members in NHS England, and between the public. And it's not just the public as patients, but the public as citizens. And so there is something about the nature of the relationship of accountability that says how we listen and speak to each other shapes how we work together. And so the human relations model is saying that we've got to address those issues of listening, respect, patience, mutual accountability in a way that allows everything to work for the patient and allows NHS England to say our staff are learning to listen and speak in new ways with new models.
Okay, thanks, Leslie. Sorry, folks, if you had two voices speaking over the
But they were both from the
loudspeakers there.
Tavistock Institute, so it's beautiful.
So both talking about human relations.
Yeah.
Great. Well, we're actually, I think
we should do another one later.
Yes. Well, yes.
Yeah, let's do that.
Yeah, we'll do more of these later because there's various points of group work during the day. So we're going to pull in people to talk about aspects of NHS Citizen. So for now, thanks, Leslie, and we'll be back to the plenary in a moment.
Thanks, Clive, and you guys keep watching.
And I would be really interested. It would be very helpful to hear what your thoughts about what came up for you and what could be, what it was like and how it could be improved if possible. And if you can write on some of the bits of paper your thoughts, and as I said, put them on during coffee and tea in a few minutes. Put them over there where Leslie is demonstrating. That would be very helpful. Has anybody got anything? I think I saw Sean's hand up. Do you want to go first? Oh, Mike's. Thank you. Sorry, no, of course.
It got me thinking in the premium domain.
Yeah.
I think at first there were too many voices, but if a person with learning disabilities and people with physical disabilities and old people feel like they've got no voices.
Right.
What I think we need to have advocacy workers and peer-to-peer support. And people with learning disabilities can be excellent advocacy and support work if they go to doctors. I depart a young lady. She had a learning disability, but she finds talking very difficult. I worked be a support worker when I went to doctors. I think NHS needs to look at this,
right?
That type of work, because there's a lot of people with learning can do that type of job.
And in the group that you were in, when that conversation was going on, what else was going on with other people in that group? Were you being taught to, or was there different kinds of?
At the first, there were too many voices.
Right.
And what our group said, we need to work together.
Yeah.
Because if you don't work together, people get isolated and people lose confidence and they have no say.
Yeah, and it's really interesting to me that you say, first of all, there were too many voices. And I think that's what part of the thing we're thinking about in that discovery lab. There's so many voices. How does everybody get heard? So it's really helpful kind of observation. Do you think you could hand your mic on?
Stuart, one of the things that came across very clear was that we all have our own preconceived ideas about what other people can supply. I stood as a private sector and was immediately attacked about taking things away,
right,
without having a real understanding that there are other things that we can do. We can actually facilitate engagement far better than the NHS can. We can support voluntary sector. We can take a little bit of money out of the NHS because they've got plenty.
That's why you got into a fight, is it?
Yeah. But it is. We really do need to understand what everybody does. And because we have such entranced positions, we block other people coming in. We have our usual suspects, and I've come across it a lot, who block new people coming in, a more diverse relationship. We have some members within the NHS, some of the professionals and clinicians who block engagement because they don't like it. We have some of the managers who block it because they don't understand it. And I think we need to have a magic wand that says, let's just listen and look at what we can bring to the table, that we may not agree with some of the things they do, but what they do bring is of value.
The point about we have kind of preconceived ideas about what people are like and what they're bringing to the table is one I know that victim to sometimes too, and it's a really important point. You, and then you, and I'm sorry about your names, I'm sorry, go on.
Okay.
Dawn, that's right.
Yeah, the one thing I noticed was I was playing the nice little quiet patient, well, I wasn't for 2 minutes, and then basically what happened was everybody turned their back on me, and I'm sat in my little wheelchair thinking what the hell's going on, as most patients do, and the conversation is somewhere over here, and I'm about as involved as a walnut whip factory. I'm the very last one to find out what the heck's happening. I'll just get stuck on the top, you know. Now, I agree with what you said about the privatisation. I think it's coming, and I think what will happen is there will be certain centres of excellence. Do I think it's bad? No, I really do not, because these guys are going to get paid no matter what. I think if they've got centres of excellence where they're doing certain procedures, which that is all they do, they will flourish and they will become even better. I mean, we've noticed that at Charing Cross, for trans girls who go in for their operations, the infection rate is quite high, whereas at the private hospitals, it's exceptionally low. Draw your own conclusions.
So we're going back to the point that it's about listening, it's about having the conversations. It's actually about, I think, and I know that part of when we became involved in this, part of the NHS England board, the members of the board that have promoted this work, was about saying we have to have proper conversations. How do we help? How does a system help people to have proper conversations?
But it's deeper than that, because what's happening at the moment is, again, the patient is the one that's left behind. You know, the patient isn't listened to. You know, the doctor will do the initial listening, and then you then ended up in a situation where you hit a brick wall. You don't know how to go forward, and until something's done about that, and actually allowing you to look over that wall and see where the various groups are. You know, I'm sick of the attitude of being patted on the head, and there, we know what's best. No, we don't. I know what's best for me, and I just need that help in how to get there, as does everybody else here and the patients.
Okay, thank you.
Camilla, I've been spotting a few more hands.
Yeah, sure.
Over there, and then we have, I saw you, Janet, and then Jag, just so you know.
Yep, be in charge.
as a pure citizen, in the group I belong to, and our friend over there was nearly killing me, it came out as one word, or a few words: who listens to the citizen? And that's the most important thing. If the citizens aren't listened to, then this whole concept is dead. And when you start to look into this, who actually, as you've just said over there, who actually listens to the patient, the citizen? And that's what we've got to get across. The people who we are citizens, therefore we've got to spread a message that we must be listened to. Whatever we say, if it's crap, fine. If it's not, then please listen.
Okay. Thank you.
It's along the same lines. In our group, we found that the patient and citizens end up on the outside with the advocate, and the commissioners, NHS England, voluntary, all talking together in a group without us being involved, which is quite often what seems to happen.
Yeah.
In real life, yeah, I agree with that.
My question is to the board, have we got learning disabilities on the board? The people who have learning disabilities working for you, with you rather?
Well, that's a question we can put back to the board when we talk to them and so on. But I think the answer is probably no.
Why?
Oh, well, that I'm not going to answer on their behalf.
Just picking on that trend, so what I heard was, do citizens get listened to? There's a brick wall. So the answer, if I was devil's advocate, and I have been in different roles, as some of you may know, I'd say, well, I get the satisfaction surveys that are 95%. The metrics that are telling me there's less deaths show to me that we're doing a good job. I'd be saying things like, you know, We get the patient in the boardroom and we've listened to them. And then if I flip that around and I ask myself the question as a citizen, so the patient came to our boardroom, he said the story or she said the story. Yeah. We were all very, very sad and upset or very pleased with a good story because normally they're good stories. And then we go back into the unit and talk to the director of that unit and say, what we're doing about this case. Yeah. When do we feed back to the patient? We do. And my board at LIP, it's a service user board, always say to me, really good guidance, we don't know what happened then. And I think there's something around NHS England's new team trying to promote what's best practice, what your expectations are, because you have got a powerful role. And you know, I think that's the answer to some of the little bits of how do we look at how we do things differently. How's the culture going to change? Yeah. Because you've got these metrics, and I'm going to keep pushing until I go probably. Metrics, they were good for a certain time.
How things are measured.
Sorry, forgive me. So, you know, there's things that everybody gets measured on. So I'm measured for certain things in my board, but the NHS bodies are measured for certain indicators, and they show how well they're doing. So there's a thing that they get measured on. How are patients satisfied? There's a family and friends test coming up, you know, and they're indicators to the board how well the organisation's doing. Now, satisfaction's great, but should we not be asking people how they want services to meet their needs? And I think we're in a different place now.
Yeah, it's a different set of questions, isn't it?
Yeah,
Are you satisfied with what you've got? Are these the right services anyway? Is the different question, and I think that's the kind of question.
Sorry to go on.
No, that was very helpful. I think a lady here and over there. After.
Hi, I'm Jason. I'm a number of different hats, but I chose to be a commissioner because I'm a lay member on a CCG, quite a progressive CCG. What I wanted to say is that I think starting from the assumption that nobody listens and nobody has good practice is quite dangerous, because I think we do have some fantastic examples of how there has been changes in the way that people have worked, how that organisations have started to think differently around ongoing relationships with local communities rather than just patients because we have to, because we'll get taken to court if we don't do it. And actually a conversation that's a conversation about what matters to you rather than we're going to close this hospital, we're going to develop this service. So I think there's something about how we start to capture some of that really good practice, and that we look at how boards have become much more visible, much more engaged, much more having a relationship with people. Yep. And I think there are still barriers. Nobody does it perfectly. There are still bits of work that I think, listening to the conversation today, that I want to go back and do, and conversations I want to have with people. But for me, there is something around how we take what we have already and recognise that isn't 50 million people. That's probably a very small number. So how do we reach the rest? And how do we then enable anybody to express a voice? And I think I'm hearing some really good stuff, but also I'm a little bit worried that we're going to lose the really fantastic stuff that we all do as well.
Yeah. I agree with that. Have you just joined Jason's fan club?
Nothing without the microphone, please.
Hi, my name's Sasha, and I chose to be a citizen in our role play and found it quite interesting. We had 2 citizens in our role play, and I guess what I found is just similar to how somebody else mentioned, that at the beginning there were too many voices, and the person who I thought I needed to speak to wasn't visible, the health professional, because that's the person who I would have thought is the person I need to speak to, and that wasn't visible. And then when I did kind of see the commissioner, I didn't understand the language the commissioner was using, so started to distance myself, whereas I felt that the other citizen actually started talking to some of the other organisations. And as the conversation went on, I disengaged more and more. And it was really interesting the way the commissioner was trying to engage with me was by showing money, kind of, and it still wasn't working. And I was still very disengaged. And as kind of the whole role play carried out, out, the commissioner eventually came and spoke directly to me, and we started having a really useful conversation. But by that time, it felt like the power of the influence was already over at a different, and where the action was happening was somewhere else, where actually then the voice that I had didn't know how to be part of that. And also then that structure over there, where restructure and...
You restructured?
They restructured, and so it was all very different. And so very much then kind of, although having a very useful dialogue with the commissioner, very much on the outlines. And then that's sometimes, I think, some of the groups that we work with, particularly in Bradford, is very much how some groups can feel that although there are very good structures to engage with, and they do engage very well with citizens, there are some groups that don't, as much as they want to, can engage with that. And when they do, by that point, some of the influence and power that they can have doesn't enable any changes to be made for them.
So it's something about getting it right from the start. Right from the start.
Yeah.
I think that might be a good place to draw to a close for coffee.
Oh yeah. We do have two more, but I
oh, so sorry.
Why do you think?
Do you want to do two more then? Yep.
Should we get just Sean and Stuart?
I mean, when you talk about people, no, but I feel like done time. If you've got the biggest voice, you get all the power. I'm thinking we need to change that from smart people not being all power to be equal. Be too many people with got no power not being listened to. That I'm not having to go at people. Too big organisation. The only thing they're bothered about is money. They're not bothered about people who want to change things. People like us, like myself, we've got a voice, and it's big confidence. We're not getting even invited to, and it's so frustrated. I had to put a Twitter on over there to put my voice across, and that way, big organisations, they mean good, but they need to invite people we know to have a voice. That's what I think.
Thank you.
Yeah. Pass it on to Stuart.
Yeah.
I can well understand how citizens, and I'm one, who don't get their voice heard. When my consultant took 6 months to realise he'd amputated the wrong way. I think we've got to be a bit honest within the NHS. Your local GP has not got the time to sit down with all your family and tell you everything that you're going to need support on after you've got a long-term condition. It's unfortunate, but they haven't got enough GPs. I know of GPs practices where there's 12-week waiting lists, where you can only take 2 conditions. And I think if we can admit that the consultant hasn't got enough time, the GP hasn't got enough time, then we look for other resources that can actually provide the support for the families and for the citizens, what they're going through, then we might be able to relieve some of the pressure off the GPs. And to be honest, my GP, my CCG, which I used to be a lay member of, announced we're going to be £100 million in deficit within 12 months. The cure is to push everything from secondary into primary. That means your GP will now not have any time to see patients.
I know that's not fair.
Okay. For me, anyway, that was really interesting to watch and be part of some of that kind of movement in the conversation. I think you're really right, Jason, that we have to remember there's good practice. It's easy for us all to slip into the negative. Again, it's about joining up. It's all about joining up the good practices and even the things you were just saying there. It's a system thing. I kind of can't help but think about how the joined upness of our system. We're going to stop now for coffee. If you've got anything to write on, put them on the wall, please. I can see some things going up, and I saw those two scribbling furiously. And Anthony is reminding me he wants a minute or two to say something.
Not even a minute. I just wanted to say that tomorrow we will be testing out the Gather space. We'll be talking about Gather. And to do that, I would really love it if you could put an idea that you would like to be talked about as an example during that session on the flip chart that's at the back by where the coats are during your coffee break. So if you could just stick an idea up, we'll pick one of them and we'll work it up so that we can use it as a real example tomorrow.
Thank you. Thank you. And as you move into your coffee and tea, can you just observe the groups you end up sticking with? It's really, really fascinating who you've sat with and who you've stayed with, and see if you can't break out of the groups and break out of your jargon. So I'm going to give you 15 minutes, and then we will come back and we will start the real work. Sean, come and ask me, and then we'll bring in.
Start the real work.
That was just awful. I'm so sorry. Do come to order, please, people. It's the facilitation team that's the worst. We're going to call you out on Twitter next. So, welcome back, everybody. What we're going to do now, this is good. Is it not quite? Oh, it is afternoon. Yes, good spot. So, this is going to be the last time that we talk at you. The rest of the time is us working jointly together, but we felt like it was just important that we got down into a little bit more of the detail about how each of the bits of the system fit together, or work and will fit together, so that you can then really engage with what it is we think we're doing, so you can tell us what we're getting right and what we're getting wrong. So about 15 to 20 minutes maximum of us talking at you. And indeed, Olivia, can you do a timer and just call her? I'm going to give it to Olivia because she's got her trusty timer that she's used well before. But thank you. We might call on you later, and she's going to cut us off. So what? 4 minutes. So how has the NHS Citizen model changed? And we're going to start off because she's definitely ready, even though I can't see her. She's gone. Catherine, it's you.
Okay, so the main way in which the Discover layer has changed since we started working on it is that we're spending a lot more time thinking about online, offline connectors. So we're thinking very seriously, we think that we've got quite a clear picture about how you could connect digital conversations together, but what we need to do now is to make sure that people are taking offline conversations into that space, and also we're taking these kind of events into offline. So that's why today we're testing the live link, this event we're testing the live link with East of England. So there's going to be a bunch of people in Cambridge working remotely from us tomorrow. So we're testing things like that. I think the other thing on Discover, which has kind of like become clear, is the importance of making sure that everybody is in control of their own identity and your contribution, so that you've got control of your data and you know where it's going and that kind of thing. So you're in charge of your own contribution. Apart from that, the thing which is really clear is we need to start building stuff. So we've done quite a lot of talking and we've tested some ideas, but in the next phase we've become really clear. We have to start demonstrating some of the stuff that we mean. So expect to see some prototypes with crazy designs and things like that, which you can comment on. That was it.
So now, Anthony and Gather.
The two main things.
Not without. Oh, you've got a microphone.
The two main things that have changed. Mike? Yep. The two main things that have changed on Gather is the first being that we learnt from the expo that people put up lots of very related ideas. So at the expo, you'll remember if you were there, we had a dozen or so ideas about accessibility, and rather than just picking one, we merged them so that we could have a better conversation. So what we've done with Gather is we've made it so that people can merge similar ideas or have the option of merging similar ideas. The other thing that has changed about Gather is that rather than it just being you stick a flag in the ground and you say I want to do this and then you have a conversation about it, there's a little bit more structure, a little bit more process to make sure there is a chance to make sure that you have the right network and evidence around the conversation, and also to make sure that you know that it's going to the right place. And finally, we've added a feedback loop, because we know feedback's really important, so that when an issue is sent to the NHS for response, there is a place that the NHS response will be shown. And we picked that idea up from some people in Exeter who were saying how good it was, the way that patient opinion did a little green bubble if something had been answered, a yellow bubble if it had been partially answered, and a red bubble if it hadn't been answered.
Thank you, Anthony. So then it's me talking about the Assembly meeting. So the Assembly meeting was the least sketched out, the least drawn out in the document in October, partly because we all know what it's like to bring a group of people together in a formal meeting, and partly because we wanted to engage people in the conversation. So we've done a literature review. We've read lots of other accounts and case studies of when people have held these sorts of meetings to identify the questions and tensions, the problems they've identified. And then we tested the expo for an hour in front of 3 board members, where a number of people from Change and others here took part, where we tested how the Assembly system might work. And that raised a number of questions, and we've now designed a process that we want to be running past you. We want to get you to hear, and we will be doing something like this, depending on what you say to us today and tomorrow, at the AGM on the 18th of September. And you're all now putting that in your diary. So we are expecting to have about 250 people participating in the Assembly. It will be open access to about 75%. Anybody can come. And then we will be looking to see, well, who's missing? We've got lots and lots of people from this part of the country, or we've got lots of advocates for this disease, but nobody for this. So looking at who's missing. So a mixture of open access and recruitment. People who take 250. Gather will throw into the Assembly between 3 and 5 issues, and the Assembly meeting will happen over the course of 2 days. For the morning of the first day, there'll be setting the agenda. What do we think about these issues? Which one should get more time, less time? People will then break into groups to discuss the issue. What more evidence do we need? What questions do we have? Coming to the point where they begin to say, right, this is the question the board has to answer, or actually, you know what, we don't think this is for the board. We think this can go elsewhere. And then the last afternoon of the second day will be where the Assembly, the full Assembly, will sit in front of the board with the questions, the thoughts that they've had during the previous day and a half, and the board will sit and formally answer them. And I'm being told to stop, so I'm not going to say any more. And then we go into Camilla talking about human relations. Can't believe I spoke for the longest.
I feel like speaking slower. And I think that's one of the things I notice here, that we there are different paces. And part of this human relations stream that has been, we've added this human relations stream since the October design days. And that's partly about this acknowledgement that actually, I think somebody said it out loud this morning, for this to work, there needs to be kind of sort of wholesale culture change. So adding this stream is about a recognition that that is a really central feature of this programme. It won't work. In this document, actually, there's the diagram here, which is actually, I prefer it to, see that one actually got the human relations there around the edge. This is the system swimming in a sea of human relations. It's this kind of sweat. Catherine said that, sorry, I thought it was great. And that's what it is. This is all about the human relations. And this is us trying to focus on, as we were doing this morning, what needs to change. But it's really not about us doing it, but it's about linking up systems, finding connectors, who's doing it, where are the good practices, how can we spread this word, of which you are all a part. So that's what is different from October.
Thank you. Great. So what I want you to do now is to get into pairs initially at the start, and to answer, there are 2 questions on there, but actually I'm going to ask you a third one as well. The questions are, one thing you like about what you've heard, one thing that still raises concerns for you, or you've got questions about how would that work. And then actually I think there is a third question, which is that we've still been very abstract, we've not been giving you anything concrete, physical to think about. Do you have any questions just about how this is going to work? So I'm going to ask you to do that in pairs for a few minutes, and then I'm going to ask you to join with another pair and begin to kind of identify what your key things you like, key things you think need more work, and any really important questions you need to get to, and then we will come back and we'll draw all of those out. So in pairs first of all, and I'll tell you when to move into bigger groups. I've said this so many times, the NHS Citizen team is bored of it, but I used to be a teacher and I quite like shouting. So can you now take your pairs and find another pair. You might even want to move table and find a pair that you haven't spoken to yet, and have a conversation about, Leslie, just a second, have a conversation about those questions again, and just begin to say, well, what are the absolute key things? Can you bring it down to 1 or 2 points? You may not be able to, that's fine, but talk now as a 4 about your conversation and begin to identify and distill out, get the important bits of those questions. Thank you. Sorry, guys. Thank you. Another 5 or 10 minutes. Okay, everybody. So, welcome back. I'm trying to be nice and calm and gentle, and trying to not shout at you and resist using Olivia's pink fluffy whistle. And I know the conversations are very rich, and I know the conversations are very useful, but what I want to do now what I want to do now is just begin to pull out the really important things. And I've asked you 3 things. I'm not going to do it in order. So anything that you want to say as your group, either things you liked about what you hear about NHS Citizen, things you think raise questions or concern you, and then any practical questions about, well, I didn't understand what you were saying. What I'm going to do is I'm going to ask each group just to give me one thing, and we'll go round, because what I don't want to do is hear from one group at length and then say everything that every other group says. So why don't we start? I always head to the left, so I'm going to start with Tim and Stuart. And Sonia, if you can help me with the microphone, please. There you are. I don't know. Oh, I'm sorry, Steve. Sorry.
Thank you very much for apologising.
I always get called Stephen for some reason, so if you can give it to... So just give me one thing. Why don't you start?
Okay. Right. Can everybody hear me? Yep. Right. One thing. The difference between the major illness groups and the non-major illness groups, and the power the major illness groups have. Will the non-major or the little guys be heard?
Right. So it's again coming back to Dawn's point about who's going to get lost and people getting lost in the system for different reasons. Tim.
A positive is that we generally really liked the idea of a group of normal people sitting with the board, telling the board how it is for them.
Great. Excellent. Thank you. Let's go on to that table. Stuart or somebody from that group, one thing from your group?
Is the cultural change that's got to take place between the patients and the public, amongst themselves, and amongst their relationship with the NHS. And the NHS cultural change where they've got to do a change amongst themselves and with us. So it's the cultural change between we've never spoken to you, now we are, and we've got usual suspects who are trying to block everything because they don't want to lose their power.
And your observation is that NHS Citizen has to do this in order to be successful?
It has to. You've got to...
Keep the microphone, sorry, again.
You've got to involve everybody. And we are going to put people's noses out of joint. And we've got to accept that. We've got to thank them for all the work that they've done, involve them still, but take some of the work that they were doing and dish it out to other people. The more people that are involved in a productive way, the more this will become very pertinent.
Great. Okay, that's very helpful. I can see one here, and then we'll come... So, I've forgotten, sorry, is it Bob? Jimmy, sorry, Jimmy. I'm going to learn everybody's names.
There's one thing, well, I agree with our colleague says, there's another thing. On the Assembly, how are they going to choose the people, by election or whatever? Because it should be democratic from all ends, and in conjunction with our friend says.
And I think that's one of the significant tensions in how you define the membership of the Assembly. Do you elect people? Do you select them? Do you have it open access? Each of them has good points and bad points to them. I know there's some... in fact, Kate, I didn't let you speak before, so I'm going to let you speak now.
We have a number, but to pick up one, it's recognising that the system needs to be made simpler. And perhaps the way to do this is to start at regional and local level first. We're trying to be too big too quickly.
That's interesting. Okay, great. Just to say, I'm not going to give you a chance to say one thing and then nothing else. We will come back round again. Let's come onto this table and a group here. Anything that you want to say as Sonia's bringing the microphone. Anybody want to pick up? Max? And then we'll come
from Max. Just that we felt that the role play showed us how citizens are best heard when they organise themselves. And so we wondered about a potential weakness in the system is those who feel unable to organise and those excluded groups. So rare diseases, people suffering from loneliness, perhaps people that don't naturally organise well. We hope Gather will allow them an opportunity to have a voice.
Or people stigmatised by society or all sorts of other things as well. Yeah, I think and that comes back again to Dawn's point. Atu.
I think on our table, I think what we liked was actually the genuine attempt that has been made to understand what the individual or the citizen wants. I think it's a genuine attempt by NHS England to understand what it is we need. Something that perhaps hasn't happened before. So I think that is great. So this is something that we admire.
Great, excellent. Let's come to Jag. One thing, Jag, you like or questions?
I like everything, to be fair.
We like Jag.
We positively. We like the point that it's genuine co-production. We all feel like citizens as opposed to professionals with senior hats on and other not so senior hats like me. So those are 2 points that we did like.
Oh, you're taking a massive... I'm going to
stop
you there.
Points we like.
We'll come back. So I just want 1 point so we don't get lots of repetition. Somebody else from a different group on this table? Okay, they don't want to say anything. That's great. Anything you want to say? Yes, Janet. It's been said already. Fantastic.
How will you make sure it is not the usual suspects who sits on the assembly? How will you mix it? How will you mix it up?
That's a really interesting, and it comes back to this question about election as well. How do you stop the usual suspects, as they're called, sitting on the assembly? Elections may get you new people, or it may be only the usual suspects who stand. Open access risks bringing in the usual suspects. I will come to you, Dawn, but I'm actually going to go to the table behind first, and then come to you. But is the back table on the webcast? They can be seen. I'm getting a nod. Good.
We liked the discovery bit and all the connections, and could see lots of citizens having involvement there. We were unclear how things would get from discovery into Gather, and who would find the evidence and do the hard work to shape the stuff up for consideration by the Assembly.
Great. I think that transition from layer to layer is a really important and challenging one. And I think that's one of the things we're going to want to work on. Just to be clear what's happening as Sonia's bringing the microphone forward, Huda and Leslie are capturing all of these things. They're going up on there, and these will then begin to form the basis of the conversation this afternoon. Dawn, and then I'm going to bring Clive in.
Yeah, one of the other things we sort of like came up with was the issue of trust. That the fact that if you are struggling to get your group or your individual problem heard or treatment heard, that there is some form of appeal that you can go through that is transparent and that is open. It's got to be open. So much seems to happen behind closed doors. You know, it's great when we get something like NHS Citizen come along, but there's still too many closed doors.
I think that's really... And buried in the document is a kind of placeholder that says absolutely central to the whole of NHS Citizen is the complaints and response mechanism, so that if people feel that they haven't been heard and they have a genuine complaint, that there's a way for them to get a response, so they're not kind of... Openness can begin to hide some of those things as well. Sonia, can you give the microphone to Clive so he can bring the world in? A couple of points from Twitter, Clive?
Yep, a couple of points from someone on Twitter. Bill Russell. Bill's not in the room, is he? No? So in which case, hi Bill, if you're watching online. I've just turned my phone off. Bill's made a couple of points. I think these come into the sort of challenge category, perhaps not quite things he doesn't like, but more challenge to NHS Citizen. So this, NHS Citizen, will fail unless you can find an answer to getting those who don't come to meetings involved in some way. And he makes the sort of corollary point, jargon. He makes a similar point. Don't expect people to come to you, go to where they are and talk with them in their space.
Yeah. And that goes all the way back to what Kate said as well, and I can see you, Steve, saying the same. Come back, because there was somebody on this table wanted to make a point that I ignored. No? So I'd like to move us now into the questions you have that you think need to be answered about how the system is going to work. Are there serious challenges, things you think, unless you sort this, it ain't going to work? Oh, okay, so we have one here. Clive, can we have it to the front? Yep. And okay, great, yeah. So we've got Joe and then Deb.
I think I'm going first. So this kind of thing has been done before, and it's great. We've now got people in the room who still keep going. Because that's real. This has been done before, but this is being done in a more, I think, robust way. So to keep that robustness, let's make sure that we've got the facilitation tools to manage this really diverse group of people. Because actually, to do this well, it is a discipline. We have the mechanisms, the tools to do it really well. And so let's build that. And lastly, I feel very much this notion of usual suspects can exclude people rather than include people. So if we want to take that term, all of us here are usual suspects then, because we're all involved now. So let's build on who's already involved and involve more people. It's more productive. Let's not knock ourselves.
Go where the usual suspects have the energy to be involved in the first place, and it's about building on that energy, I think. I think that's a very good point. I'll take it, thanks. Deb.
I guess it's about making sure that you can involve people who aren't involved, who maybe don't have time to come to meetings, or young people with young children, people who aren't often involved in this because they're not using services at the moment, but they will in the future, maybe.
Yeah. So think that's you've identified a new role. There's kind of the roles that people hold already, but actually we have the kind of the young citizens who will play different roles in the system as they grow older. The people like me who are going to become old in the future. I'm not old yet. Yeah.
How is 311 going to be involved in this?
Very good question. There's large parts of the system. There's 311 and lots of other bits of the system. And I think I saw your hand up behind. Yeah. Can we explain 311? Yes. Sorry. Yes. Explain 311 to us.
Yeah. It's very, very simple. 311's an American system. It's used by people like New York City. If you have got a problem, you dial one number. That number, you talk to one person. That person then takes the problem to the department. In this country at the present moment, you look through telephone book after telephone book after telephone book to try and find the right people. NHS are introducing 311 into UK at the present moment. There's 2 pilot areas. And they will take everything, compliments, complaints, you name it, they will take through 311. A slight problem occurred on one of the checks they're doing at the present moment. If you take a well-known supermarket name, high street shop, the complaints on that shop are treated and answered within 24 hours. NHS are taking 11 days.
Thank you. Pass it just behind.
I feel we need to be honest as well. What this is going to achieve, what it can't achieve. Don't promise the public things they're not going to be able to achieve. So this is what we can do, this is what we can't do. Otherwise we'll get deflated by, we're promising to do this, and in the end we can't do it. So honesty, up front, from the start, this is what it's about.
I'll come to you in a minute, Dawn. Is there anybody who hasn't said anything yet who'd like to say something just before we... Okay, Dawn.
I think you are right. I think it is us, the usual suspect. I think when we set guidelines up, which we're going to have to, for the way we treat people and do things, I think those guidelines have to be virtually set in stone to a degree until they're changed or what have you. But I think at the moment there's too many groups who can pick and choose out of those. They can cherry pick what might be the cheapest in their area. And I think also there's an underlying underutilisation of local community groups who can deliver services for the lonely, etc., people who are struggling with Asperger's, etc., who can help individuals in such a way that the NHS can't. And I think that's where the NHS needs to grow. And I think they need to be included in the citizenship as well, that we need to be using those local groups. And amateur or what, that they deliver services and deliver it cheaply. And that's the work, I think, for this at the moment. They come under budget well and truly.
Great, thank you very much. So in a minute, I'm going to try and summarise and then release you all to lunch. I've got a couple more. Is there anybody else who's got something burning to say beyond the hands I can see? Okay, well, I'm going to come to you three, and then I might just see whether anybody else. Sean, and then Stuart, and then Joan.
At Change, we've got a words and pictures team. We make everything jargon-free. We are experts at making information accessible. We can train NHS to make that information accessible. We can train them. We can do everything with them because people with knowledge about training are the experts.
And I think that comes back to Joan's point about needing facilitation tools for facilitating diverse groups. We've already prepared a handout today that's no use at all for people who are partially blind. We need to make the type much bigger. So, and you pointed it out very clearly to us. So there are things that we need to make sure we get right here. Yeah.
I think one of the big dangers we've got is if we become a complaining group. I think we are so, we knock the NHS left, right and centre. Let's admit they're getting enough of that off the press at the moment. We need to support. I would hope that this becomes a supporting group for the NHS. We use it to tell the world how good they are. We can still have a moan at them. And I'd like to see the board use the citizen group for their use. So they come to us and say, we've got this policy, we're not quite sure. And we all know they're the usual suspects sitting on the board anyway. But we need to work together and we need to support each other. Otherwise, the board are going to get fed up with us complaining all the time. We're going to be infiltrated by certain groups who want to complain, and it will just fall to pieces.
That's great, thank you. I was trying to do two things at once, listen to what Stuart was saying and think about how I was going to summarise it, and I've forgotten whether I came back to you or not, Dawn. Did I come back to you? No.
I agree with what you were saying there. We really do need to look at the interaction between private and public here. I think in certain instances a lot of strain can be taken off the NHS by actually simply just filtering out. We're going to pay a lot of these guys anyway who are consultants. They're going to get the money one way or the other. I don't see the problem in some of the procedures we do within the NHS going to, I always know privatisation's a really filthy word, but I think sometimes it brings excellence as well. I'm not a board member of anybody, so I've got no actual financial gain from this. But I think it does work, and let the NHS do what it does best: care for patients.
And that seems to me like one of the key issues, one of the issues that will come through the system very, very clearly at some point or another. Sorry.
Very short. It was just a process point on the gather bit on the model. So we know that in lots of arrangements like this, there will be people on the edge and people it's harder to get to, or we just don't really want to hear, so we don't go and get to them. So if we're going to gather information, it is very clear that you're going to get information from sets of the population who think certain things are important. You might already have thought of this. So if you're then going to group those issues, we just need to be thinking about what aren't we hearing and how we gather that as well. And you've probably already dealt with that, but there's a way to put that on here somehow.
We haven't thought about it in the way you've put it, and I find that quite helpful. At least I haven't. I think that's quite helpful. I've worried about how you stop it being taken over, but I hadn't really thought about how do you spot what's missing, which is a different side. Yeah, I've got Jag, and then I'll bring Clive in, and then I am going to stop it so we can have actually a slightly longer lunch.
Just to follow on from Joan's point and yourself, Simon. So, for example, we're involved in Leeds Innovation Hubs, which is something that Leeds City Council are driving. And they make a conscious effort of getting in touch with us and having conversations with us that they'd want 4 to 5 service users that fit this range to be involved from I mean, this time it wasn't the beginning, unfortunately. It was a bit down the line. And I think they're the sort of things that would help me to make sure we include vulnerable people that are already here. Because we can't be, all of us can't be expected to cover everything. You talked about Braille. We've got members of our board that are blind and visually impaired. I still get that wrong, and I can't seem to get it right. So I think it's about utilising other skills that we have.
And being open and being able to be challenged openly and not responding, kind of hiding it. Clive.
Thanks. Just to bring in another voice from Twitter, just to add to the conversation that has been already had around the term usual suspects. East of England Citizens Senate have tweeted to say that they're not happy with the use of the word usual suspects because it's not clearly defined. Who are we talking about? So it's a challenge to the use of that term.
Great. I'm going to turn off the microphone. So we've heard a lot of rich questions, and I think there are a number of themes coming out. There are themes around, well, a couple of people raised the point that we can't do everything. The NHS can't do everything, and the NHS Citizen can't do everything. Some questions about making sure that we have a real, genuine diversity throughout the system. A couple of questions about the boundary between the layers in the system. And a lot more that you will be better able to summarise for yourself than I am. So what this session has been intending to do is to lead us into the main bit of today, which is the open space. Anthony's going to introduce it, and then I will quickly close off before lunch.
Okay, so after lunch, we are going to be in an open space session. And for those of you who've not been in one of those before, it means that at the start, immediately after lunch, we will have a bit of a think about the ideas and the questions that we want to work on over the course of the afternoon, or rather that you want to work on over the course of the afternoon, and that you'll then say, I'd like to get some people together to talk about this. We've got, as you can see on the flip chart over there, 6 spaces and 2 sessions, so we can pick up 12 things, we can pick up more if there's a need to pick up more. We've got lots and lots of things that have been raised already that people can talk about. So over lunch, do think a bit about what's the thing that's really kind of nagging away at you? What's the thing that you'd like to get a few people together to really work up and then feed back to us so that we can make NHS Citizen better? And after the open space sessions are finished at the end of the day, the team will be in a room with pizzas and late nights rewriting the model, taking into account the things that we've come up with today. So that's the task for this afternoon, so think about it while you're enjoying your sandwiches.
My natural inclination is to rush and say, right, I put aside 45 minutes for lunch, but let's only have half an hour. But actually, we've gained ourselves some time, so let's take an hour for lunch. The lunch is being brought in now, so just before you go, so can you come back at 1:45? I'm actually going to go for a walk to get a bit of fresh air. I'm going to go over to the Swarthmore College because I did pottery when I lived in Leeds, and I'm a bit of a pilgrimage for myself. So if anybody wants to come across the bridge to see where I did pottery, they will be really exciting, just to get a bit of outside air. And that's it, really. I'm going for a walk. Anybody want to join me? Back in an hour. Thank you all very much indeed.
Hi folks. Okay, I have with me Camilla Child from the Tavistock Institute. So thanks Camilla for your time. We're just about to reconvene as a plenary, so we'll have a quick reflection from Camilla about the day so far. So over to you, Camilla.
Yeah, it's been, so far, incredibly interesting day, and has really reinforced our kind of commitment to, I'm kind of part of the human relations stream. It's really reinforced our commitment to the work that we're doing on that in terms of culture change. There's so much I've heard today, which has been about the need to join up services, to really get people talking together, to have real open and honest conversations together. And we're working really hard. I've been working all day thinking, how can we help to make that happen? Because we can't do it for people, but we want to facilitate spaces, create spaces where people can actually operate better, more honestly, more openly together. And another really important aspect of that is how people engage, both NHS England and other commissioning bodies engage with citizens directly to have open and honest conversations.
Great, thanks, Camilla. Just one question, if I may, following on from that. So, what are some of the sort of challenges that we might face in allowing people, helping people, facilitating people to sort of open up and have those conversations? Are there sort of any particular barriers that we need to get over in the system, in sort of different power relationships, if you like, between people? Are there particular things that we can do to make that happen?
What I've really got from today is that it's an even clearer and better understanding of just how many organisations are busy at it already, and how the role of NHS Citizen is not to do it again. It's about joining people up. So the barriers might be about finding people, trying to get them together, to get organisations who have representative voices talking to each other when they often don't talk to each other already. So that's one challenge, and the other side of it is also about the kinds of and we've heard it today from people, the fact that citizens, that there can be lip service to the kind of citizen involvement and engagement, and it's how to break that down. That's going to be a real challenge for everyone to think about.
Yeah, so there's a real lip service. You know, there is lip service sometimes given, but also sometimes there's a perception that the system won't listen to me, and it's not going to be open to my voice. And I have the same reflection as you have about the sort of networks of organisations that are already doing engagement, representation, participation in different ways, and there is definitely a need to sort of bring those, make the connection, if you like, between all those different groups and networks.
Recognise the really good work that's been going on already, and I think that's been said as well today. It's very easy to say the system isn't working, I'm not being listened to, but there are actually some pockets of really brilliant practice that need to be built upon.
Absolutely, some real good pockets. Great, well thanks Camilla ever so much, and we'll hear from Camilla a bit later with some reflections on the day, but thanks for now. Cheers. Well, the plenary will be starting again in a moment, so I'll leave you and join us in a few moments for the feedback from the open space sessions. Thanks.
Welcome back, everybody. Good afternoon, nearly good evening. I don't know how much energy people have. I'm flagging, so let's do this quickly. How is everybody? So can I pull you all out of your conversations and back together? Largely I'm in your hands. The quicker you come back, the quicker we'll be finished. So, what we're going to do now, the structure of the afternoon for the rest of the afternoon is going to be very, very quick report backs from the sessions that have happened over the last 2 hours. Camilla will then take us through a quick reflection of what we think we've learned, and then we're going to stop. And we're going to go into the mode of rewriting the system document. Now, I want to check the temperature with people here. How many people want to take part in the rewriting of the document? Who is hoping? 3? What? 4, 5? What? Those people who are expecting to stay, do you want to have a long break and then come back, or do you want to kind of have a 15-minute break and then crack on? Crack on? Crack on? Is it like club afterwards? Yeah, that's what we're intending, yeah. Can I suggest a 20-minute break? 20-minute break and then back into it. Yeah, and we will provide food and so on as well. So 20-minute break, is that okay? And then, good, great. And then you'll welcome anybody to join us. So, what I'm going to do now is I'm just going to kind of pick a room. I can't remember who was in which room, and it's just possible. We'll get Huda to come back. Huda is just there, and she's going to come and put up what the different questions were. What what I'm going to do is I'm going to be very, very brutal at this point. I've got my timer. You will have 2 minutes if you're reporting back. You've got 2 minutes, and then I will gently and then increasingly less gently ask you to stop. Okay? So, just those of you who are presenting, while Huda gets the computer back up again, if you can be just kind of being ready, yeah. And if we can remember to give people kind of the space to say what they need to say and not talk over the top of them. And I'm assuming that Leslie and Huda are ready to capture things that come out that are important to capture. So we're just going to start from the top. We'll go through column 1 and then column 2. So the people who are in the boardroom, how to reach communities not already represented and hear them in a way they want to be heard. Who was doing that one? Dawn, great. Dawn, do you want to do it from there or do you want to come up here? Great. I won't start the timer until people actually get here, though, just because I'm that kind. Excellent. So, Dawn, can you report back from that group, please, just quickly?
Yeah, basically what we were doing, we were asked to report on how communities, within communities, would actually work on the Citizen. And we decided on a quite a varied approach to it, that we would need to actually get on certain communities, say the Somali communities, arrange to train to actually impart the knowledge to the younger side of the community, but also the elder side of the community. And we'd have to do that as well, break that down into sort of like tea parties, where you would actually give that information out towards certain groups. Say the women's first, separately to the guys, because that's the way the cultural would work. And then you've got to be a little bit more thinking out the box. That certainly, as I said, the longboats, which someone told me is actually wrong, because you don't want Vikings on this. Speak for yourself, I know. And we're deciding that you can actually do things locally, like having clinics within pubs, etc. I know it's not a good environment, but where you capture people who are actually on boats, etc., who are slightly more transient through communities, so they would still have a voice, but they would actually be able to be heard. And we've decided that that is the major point, that we need to educate both the elderly and the young, that we're there and we can provide a service for them, and actually their voice matters and their community matters, and that we need to make sure that they are hearing the messages that are coming through. And that's one of the problems we think we've got at the moment, that we're not doing that.
Very good. Well done. You're well within time. So it's about reaching out and going to where people are already and making sure they understand what this is about. The room, the comfy room, what does real accountability look like? Who's reporting back from that? I'm doing that. Great. Tim. I won't start it quite yet. There you go.
Thank you. We had a varied and very interesting discussion about this, and we decided that accountability doesn't fit into one tiny little box that can be ticked through this process. So we thought that the most important thing about the accountability of NHS England's board to NHS Citizen is justification for outcomes. So we think there are some commitments, some promises, some statements that we can help NHS England's board to produce, that will give a narrative about what they expect our experiences to be as contributors to NHS Citizen. And I was particularly sharing my experience of watching the demonstration of the assembly at Expo. And the demonstration of it in action gave me a lot of hope and expectation of success, because I actually saw things happening. And if we can create that narrative around a good example of people shared their views, this was an issue that was felt to be important to a lot of people, and the board listened, heard those arguments and took some action, which I think they are doing around accessible information and making information about NHS services more accessible. That would be great. We talked a lot about the accountability of representatives on the assembly. And then we realised that actually there's a risk that the assembly becomes seen as the centre and where all the action happens. And actually where all the action happens is in discover and gather. So we wanted to turn that diagram around and put the citizens and the human relations bit, we didn't like the phrase human relations, put the citizens and the society at the middle and have the assembly kind of on the outside. But accountability for action and outcomes is crucial from the board. And my final point is that there can be no better statement of intent than putting some real cash behind it, because there's a lot of cash going into various assurance systems, and the one that supports citizens has got to be the most value.
Fabulous, Tim, thank you. So telling clear stories about what's happening and demonstrating what accountability means alongside everything else. So how do we make sure we fill the gaps, identify what's already existing, don't reinvent the wheel? Who's reporting back from that one? There are no gaps? Did anybody feel competent and confident? Sasha, you look like you're... We're not going to hold her accountable for what she's going to say. Okay, why don't you go and speak to Tilly and we'll take the next group, give you a chance to collect your thoughts. How does NHS Citizen handle a hospital that talks to people in a language they don't understand? I've seen Sean primed and ready. There you go.
As a double act, basically. We'll try and do it within the 2 minutes. So our question was around the sort of handling the hospital. We felt that the NHS Citizen Assembly very much had an influencing role around this with the board. And so we were very specific in how we answered it. So the first thing we thought about with this was training. We felt that staff, consultants, receptionists, everybody needs to be better trained in how they actually communicate in a more accessible way with people that have got a learning disability. But we also felt that would be useful to know for somebody, say, who's had a stroke, for example, whose maybe speech has been impaired or has a low literacy level. Anything else you want to say?
Yeah, not just for them, but older people too, who find speaking very difficult, and to their memory issues, they can talk to them better. Yeah.
We felt the training should be co-led by people that have got learning disabilities as well, so because they're the experts. We thought it would be good to employ people with learning disabilities to provide peer support to people in hospitals, and by that I mean actually to pay them and not just rely on volunteers.
A proper living wage, because a lot of people with learning disabilities have got a lot of skills to give their time and support people when they're in the hospital, around taking people to the right ward, taking to the doctors. I'm just being there. I'm be there when they're in the hospital, needed to be to talk to.
We felt that there needed to be a lot more accessible and easy read information, and that signage in hospitals needed to be looked at. Sean gave an example of where he and his mother spent 25 minutes trying to locate a particular department within their local hospital. His mother does not have a learning disability, and she struggled to find her way around, and I think there's something around that.
My mother is not... My mum very laid back, but she was really not happy.
We felt that, well, Sean has done a recent piece of work where he's run 5 focus groups around the country looking at what is good practice and bad practice in the health services. And one of the things that did come up is that there are some hospitals out there that are listening and are doing some good work. And we felt it'd be really good to identify those good practice hospitals for them to sort of be buddied up with those hospitals that aren't probably doing as well. Maybe some sort of, I don't know how we want to phrase it, but a mentoring scheme is what we came up with. Yeah. But perhaps that's not the right phrase to use. But how for the good practice to be recognised and to influence those that aren't doing so well.
Because I feel like them hospitals are not doing a job well. Them ones are doing good. They can support them and make sure everything in the hospital is done properly. And all the patients are supported properly, staff trained properly, but it's got to be done by people with learning disabilities.
And finally, you'll be glad to hear, health passports. This is something, initiative that came up, and I think it's a sort of tell it once sort of idea where all people's medication, everything is written down. You're more the expert than I am. I know that our organisation works on making this an accessible document, but we're not sure that it's actually been rolled out nationally. And we would call for NHS Citizen and the board to look at influencing the rollout of that.
Because people told me when they go to doctor or they change his doctors, the doctors asked them what medication they take, and they don't know. If they had a medical passport, they would know they could scan the passport and they know what medication they're taking. But if they don't have one, they're making them vulnerable.
Yeah.
And that's why they need to make sure when they just join the doctors and just got into join the hospital, they need to give them an old passport and a backup passport in case they lose it.
Great. Yeah. Excellent. Thank you both very much indeed. So, Sasha, I'm not going to call on you. I'll call on you last, don't worry. So that we'll go into column 2. Who is going to do this and how will it be paid for? That was the discussion I sat in. Who did you decide was going to report that back?
It's very, very short.
I've actually missed an issue out, haven't I? But given that I've jumped an issue, I'm very sorry. It's telling which issue I've missed, but we'll come back to that. Would you like to start?
Hi. Who's going to pay? Who's going to do it, and how it will be paid for? We spent an hour talking about this and came to no conclusion. And the answer was that if we go and pay and get the NHS to pay for it, then do we become NHS lackeys or not? There was thoughts that we could go outside and get money, get funding from outside, and still be part of it. The other bit was who was going to do it? Are we going to use paid people as a secretariat? Yes. Are there going to be volunteers outside who are going to work for nothing? Yes. So it's going to rely on volunteers, a paid central secretariat, and funded by who? We don't know.
Thank you very much indeed. Great. Well within your time. So, interesting that I ignored the one that's about an inclusive space, for which I apologise. So we will come to now the final one in the column 1 around the inclusive space and how we make sure we work with people's real needs. Do you want to do it from there? Okay, thanks.
I was in this group with some lovely people from Change and some others. So we talked about that. Firstly, we need to have discussions with people, regular meetings, peer-to-peer support. And then we looked at the practical aspects, things like, accessible buildings, accessible toilets, and things like even why do people forget to assess these kind of things when they select a venue? Is it maybe it needs to be assessed when before a particular venue meeting is decided? Maybe it needs to be assessed by some disabled people with special needs, whether they need to go in there and assess whether it does meet people's needs. Things like transport. Most of the meetings are held in London, and that can be a nightmare for people to get to, in terms of using the tube. There are few stations which have lifts for people. Things like the issues about cost of carers, patients, the availability of personal assistants, and things like even if they have to spend the night, if it's a 2-day meeting, spending overnight, need for minute takers. And then we talked about maybe we need to be thinking of different ways of communication. Online is not always possible. Everybody is not online, which sometimes people tend to think they are. Maybe we can have video links for people who are unable to attend, so different means of communication. Then we talked about maybe, we need to be having smaller meetings which empowers people to speak, because in a very big forum, like we're talking about the National Assembly, people are unable to speak up, they don't have the confidence at times. So maybe you need to go from local to regional to national meetings. Yeah. Then we talked about, maybe we need to gather at a local level and then representative from gather at the assembly to present the evidence at the national level. What will be their role? Will it be just presenting evidence, or are they going to be a full member? I think I'll stop here, but is there anything somebody else wants to add?
Well done. Sorry, I didn't want to talk on. I was going to give feedback. Well done. That was great. Thank you. So now I am going to go to the second one in the comfy room. How will the board demonstrate impact? How does the board make itself visible? Great. Excellent.
Can I sit and do it?
Yeah, you can do. Yeah.
Well, on the first question, I'll take the two separately. The main thing, and I know it's something that everyone else has said, is, and it's quite an obvious thing to say, but there should be, the board really needs to demonstrate their response and the result that has become of what has been raised to them. And close the feedback loop, which is quite a common issue in many organisations, higher education in particular, with if somebody brings an issue to them, they say, we will look into it and we'll do X, Y, Z maybe, then that they need to come back and say and update what they've done as a consequence. It was also discussed that there needs to be some structure to how the board comes back. There can be informal process, but there needs to be a formal response. There was some discussion about how we avoid that being a box-ticking exercise when they just pump out report after report. But they can use different mediums, innovative mediums, digital mediums to communicate what they've done and introduce it to wider audiences, and that they should set milestones on when they're going to report back. On the second question about how they can become more visible, it was quite a strong point was raised about them attending, board members themselves attending events like this. Recognising that they're very busy people and that's not always possible, and they may need to send other staff members, but they must make themselves more visible and make an effort to become familiar and understand the principles and ideas that we're discussing here. And make sure that they're involved between meetings, which ties back into how they're demonstrating impact, and ensure that they're giving regular updates in whatever medium they want to do that from is up to them. And I think, yep, that's it. Yep.
Perfect. Thank you very much. Well done. Good. Sasha, are you ready to come in now? Why don't we? So we're now going to go back to meeting room 1, not reinventing the wheel, gaps and what's already existed. Oh, sorry.
Thank you. In terms of talking about what already exists, we talked about some of the local structures like Health Watch and local groups community groups that are available, and how we link in and work with them in the gather space. But then we also talked about learning and sharing good practice and the mechanisms we have to share that practice. So if something is happening that's really good in one area, how do we share that to other areas, and how do they know it's good practice? So looking at the evidence base around that. And then we talked about some of the other structures like the VCS assemblies, voluntary and community sector assemblies that they have themselves and how we link in with them. Again, probably things that might happen in the gather area. And then we talked about how do we ensure that when people are raising issues, that we're not saying to them that this is not our issue, this is NHS England, or this is the CCG, or this is another area, so that we make sure that the local structures, and that's responsibility for the local areas, to make sure that their local structures are speaking and signposting effectively, and allowing issues that may need to be raised nationally can be raised nationally. So some of the things that we talked about were the accessible information, or patient participation groups, and how there's issues around them locally, but some of the things that might feed nationally in terms of how the direct enhanced scheme works to support them. So how that can then actually use this NHS Citizens model to raise that discussion and then maybe create some change. And then we talked about the different structures that NHS England has, like the Youth Assembly, and how we talk with the Youth Assembly and make sure that we're connected. In terms of gaps, we talked, so going back to kind of how we thought, there was a discussion about how the Assembly might work. Sorry, thank you. And so we talked about those local structures and how those local structures do need to work in that space, so that they can raise local issues. There can be a local response to that, a local mobilisation of what needs to happen, and local accountability. But equally then, that should be reflected in this national model of assembly, that you have the issues can be raised, a response and mobilisation and accountability of that, which probably feeds into some of the other discussions that other groups were having. And then in terms of finally, in terms of the gaps, we just very briefly talked about who needs to be part of NHS Citizen, and how do we define that, and how do we make sure that they can be involved and it's open for that, and that there will be various levels of how it works, because not everything works for everybody, so that we can make sure it's inclusive.
Thank you. You did a very good job standing in there when Jason ran away. So who is reporting back now from how do we prototype in the local areas to learn? We lose the local voice. Who was doing that? Who's in that group?
You were taking the details. I was thinking about if you want feedback, because you wanted to talk about your...
So we're having some discussion for the webcasting as to who's going to report back. I'm going to leave you two to non-verbally have a fight and decide who's going to do that one, whilst we go into how do issues get from discover to gather to the assembly meeting. Who's going to report back on that one? Oh dear, we've lost all the energy in the room. Who's doing that one?
I think it's probably best if I just pick up a couple of points that were raised, or unless Tilly wants to.
Oh, why don't you do it? You're here.
Okay. So very quickly, we had a discussion that focused more on the importance of understanding that sometimes numbers aren't what's important. The importance of the issue is important. So rather than talking about the process of getting things from the discover into gather into assembly, which we touched on a bit, actually the main part of the discussion was about how we balanced the fact that sometimes a small number of people will be very interested legitimately in an issue, and other times a much larger number of people will be talking about an issue that is actually less important. So we worked out that we needed a kind of, sorry to use a horribly technical phrase, we needed like a scorecard, so that we needed to be able to say, well, this is a significant issue for these people. You know, these people are putting a lot of time into the discussion. These people are clearly expert or clearly very kind of concerned about it. And we needed to balance all of those factors together as well as just the numbers to try and get an importance rating of an issue so that it could move from one layer to another. And that's, I think, a fair summary of what we talked about. I don't know if there's anything else the participants or Tilly wants to add. No?
Great, thank you very much. We'll go to the last issue and then we'll see who won the fight. How do we make the Assembly participants representative? Should there be regional assemblies to feed into the National Assembly? Should there be delegates from regional patient groups? Who's going to report back from that one? There are people looking at who? Who are you looking at? Are you looking at Sasha? Yep. Are you going to report back from the last group as well? Are you ready to go? Okay, great. Thanks, Sasha.
Let's have a look at the notes that were on the board. Okay.
Okay, right. So we'll do another. Whoever's won the fight will. So just remind people what you're talking about, Kate.
We'll do a joint thing, shall we?
We're going to do a team where I was going to say the Beverley Sisters, but that's not
Right, I'm going to start the timer. You can decide what group you are later.
Prototypes in local. It's really what are we missing? What is going wrong? Where is money being wasted? And we talked about the need to build up what works and discard what doesn't work. And what is happening when we get a certain number of projects that are going through and they are failing. We had examples of the fact that we get something like Self-Care for You, which was trialled for 3 years, and then the money ran out and it disappeared. But it suited some people, and it's sad. That happens quite frequently. We were concerned too about the health and well-being boards, that they perhaps hadn't quite got the teeth that they should have had. And were not linking really with, as they should be, with the community and back out again. And we talked then about hearing regional and national voices, the small groups of diabetic patients, and at that point we came to the point that we needed to think, perhaps we needed to think differently. And we talked about the project in the West Midlands where we have actually copied the East of England model, which you'll learn more about tomorrow, where we've put our citizens on a level with the clinical senate, and we have a citizens' senate. That citizens' senate is there to challenge the clinical senate. Beneath that, we have the assembly, and we've decided that our citizens' assembly will be made up of every member of the West Midlands who wants to be a part of working with the Senate. They will fill in an application form, and this is important because we need to know what their skills are, whether they have skills within the health service, whether they have business skills that they bring to us from the outside world, because as I keep saying, the NHS actually could do with some business skills in places. And don't put me off. The assembly then will also be, because people have filled in an application form, will be the source of patient voices for any of the projects or the focus groups or the expert advisory groups that the West Midlands Senate are asked to do or are setting up within their own staff, their staff projects under the cancer, cardiovascular, mental health, dementia, and children and maternity services. So we really are very involved, and they're starting to accept us quite nicely. We sit on the council, we sit on the oversight committee, and we're actually allowed to play quite a part. But it's taking a bit of time, but it is actually starting to show that it works, because this is the way the local voices have the opportunity to gradually climb up and affect the decisions at national level.
You know you're in trouble when I start to sit on your lap. You've definitely gone on too long then. No, I'm joking, I'm joking. So, Sasha again, you're stepping into the breach at the last minute. So remind people what you're talking about, and I'll give you the microphone again.
We are talking about how do we make the assembly meetings representative of regional structures and that they have a diversity of voices. Before we started that discussion, there was a question as to whether it was possible to have more meetings than the 2 that were suggested, but then we went on to have a discussion that actually what would the purpose of the meetings be, and actually that would then determine the pace and frequency of meetings. So we kind of came back to actually 2 meetings might be enough if the purpose, and that was quite clear. So we then went on to talk about the diversity of groups, place and issues, and how we make sure that we capture that, and had a discussion about what do we mean by regional structures, and that we should maybe not try to be too perfect in our representation, which might then set us up to fail, but actually try and achieve something. So there was a discussion about the need to be visible and make that diversity visible. So we had a discussion around election and representation, membership of the assembly and how that would work, which then led to kind of where would that election or nomination come from, which we then started talking about the regional structures. And we talked about senates, and there was a question about whether how representative senates are. They work very differently in different areas. So we would need to ensure that we were working with all structures to listen and hear voices and the needs. We then went on to talk about maybe some standards and how that would work. So it's not, like we said, it's not possible to be perfect, but if there were some standards about being open, accessible, sharing information, having a fair process, for it to be identifiable who's taking part and understand what the discussion is, that that would create some confidence in the process. And NHS England could maybe provide a map of how the local structures feed into this. Then we kind of had a final discussion around barriers, some of power struggles, having teeth and accessibility to the assembly. And that we would need to demonstrate change or impact can happen, which would encourage involvement, encourage participation, and make sure that it wasn't a talking shop. And then just finally about making sure that we close the feedback loop, which was mentioned earlier.
Thank you very much indeed. That was great. So it's been a very rich discussion, and what's going to happen next is we're going to try and digest that and understand what that changes about the model, what questions it raises, and I think there are some significant questions raised as part of that. It's opened up the conversation, not closed it down. I think there are some places where it's perhaps less clear, at least it is for me at the moment, but that may say something about it being late in the day. So we're going to take a very short moment just to kind of reflect, and then we will just, I'll just take a couple of minutes just to say what's going to happen tonight and tomorrow, and then we will let you go.
Thank you.
So, Camilla.
Come up here. I've just,
oh,
I think
on.
I have a mic. Yeah. The idea was that I kind of think about the reflections of the themes that have come up through the day. Inevitably, if you ask one person, you get their favourite themes. So these are my favourite themes. You probably have others that have surfaced for you. It's been quite a day, actually, and I've been busy thinking hard all day, and I've seen that in the room as well, and we are very grateful for your thinking, because it helps us. I need my glasses, I'm getting cold. The things I noticed that came up several times, the one I want to say first is that it's clear that we're on the right lines, and that we need to continue to put the citizen at the heart of everything that we do in creating this model, even from the idea of turning it inside out. Yeah. I'm curious about why you don't like human relations, which whoever it was that said that, we can talk about that afterwards.
You're in trouble.
I'm reflecting. So the citizens at the heart of everything we do, that relates to the model, but it also relates to what everyone has been saying to do, which is about reaching out to citizens. Do I only get 2 minutes?
No, you don't. That's somebody phoning me. I'm very, very sorry.
Well, you can be reaching out. It's something about that. It came up several times. The fact of in all structures, it's about reaching out. It's about going to people. It's not about expecting people to come to us for NHS Citizen. Something that and it may be because I think like this, I think in terms of systems, I think in terms of how important it is to join things up. And the message coming up is about not, for NHS Citizen, not to duplicate effort, not to invent something locally where there is something already existing, but it's to join up what is happening locally, to help local people support each other to get the citizen voice heard and out there and big and strong and loud. And it's also about creating a system that's becoming a little bit clearer in my head about how what happens at local levels can be linked in with this model that we collectively are thinking about here. So joining the local, what's going on locally and what's going on locally to nationally is something that I think is emerging as a really strong kind of area for us to work on. I think the kind of focus on the culture change and the idea that that's important still remains. I've heard plenty of stories about what little things needs to happen from personal patient experience and family experience to other kind of broader kind of service kind of level issues. The change needs to come in from lots of places is what I've heard. It's not only about NHS England structures and attitudes and procedures, and that is really important. It's also about citizens becoming involved. How do we get the next generation of usual suspects? And that was something that came up quite often. And the kind of third aspect of that, although I actually don't think we should see them as separate, but the kind of culture, the continuing kind of requirement on NHS England board members to be more visible, to be out there, to talk, what's the expression? To walk the talk. Yeah. That they need to be around and engaged in this, which actually I think they are. They are with us at any rate, but also out there more broadly. I've again really noticed how this work brings up the tensions of independence and how do you create a social movement from the centre? Is that really, we need to think really hard about that. And that came up in the conversations about funding. It came up in the conversations about the kind of structures and the way that we work. And I think that's something, it's not going to go away. It's where this thing lies, and it's something that I'm certainly going to carry on thinking about. And I suppose a final kind of thought was me kind of being part of this group, working with a group of people who've been really engaged in quite hard thinking. Going back to what I said, you know, what we were doing earlier about, it's all about good conversations. And I've had some good conversations, hope you've had some good conversations. We've got plenty of diversity in the room. We need to get more diversity in order to get this really rolling out there. But I think we've kind of, for me, this day has been a good start on getting that process. And I think Simon's going to say what we're going to do later and tomorrow. But that's, I don't, people might want to add to it if we got time, or just a couple of thoughts. Be happy if you haven't. Okay?
All I'm going to say is that if you do want to stay with us to help the rewrite, that we will reconvene at about 25 to 6, and there will be pizza. Tilly may already have gone out to get it. Thank you all very, very much, to reiterate what Camilla said. The energy and time and attention you put into this has been great and really inspiring. It's a shorter day tomorrow, starting at 9:30. Much more practical. We're going to be doing role-playing and testing the system out and testing what you've discussed now. And we will finish by 4 o'clock at the absolute latest tomorrow. Thank you all so much. Have a good evening. Looking forward to seeing you tomorrow at 9:30.